Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Today, we welcome Jonathan Staloff and Joseph Joo. Jonathan is a family physician. Joseph is an internal medicine physician. They are co-authors of the book, Reshaping Health Systems, What Drives Healthcare and How You Could Change It. And we're going to talk about an excerpt from that book, How Fee-for-Service Shapes Your Doctor's Decisions. Jonathan and Joseph, welcome to the show.
Thank you so much, Kevin. Really glad to be here.
All right, let's start by briefly sharing each of your stories and journeys. So, Jonathan, why don't you go first?
Yeah, really happy to be here. So I started college in 2010, which was a time, of course, where the Affordable Care Act was being debated. And I knew I wanted to become a physician, but I realized I knew absolutely nothing about US healthcare. So I took a healthcare course at my very first year of college called Healthcare in the US, which completely changed my career trajectory and helped me appreciate that I knew I wanted to be a practicing clinician who also worked to actively reshape and understand health systems. And so I became a public health major and did a master's in population medicine during medical school. And since then, I've tried to find a way to wed my interest in clinical medicine as a practicing primary care clinician in family medicine, while also actively working to research and advocate for changing the way our healthcare system is structured. Part of that, of course, has been the writing of this book, which we're both really excited to share.
All right, excellent. Joseph, just briefly share your story journey.
Absolutely. Very similar. First of all, thanks for your time this morning. Great to be here. Similar. So I had this dream of wanting to be initially a surgeon, somehow ended up being an internist by training. But along the way, I quickly realized, just like Jonathan and Josh, that learning clinical medicine was only really one aspect of providing the best care to patients and their families. And so I think throughout my training and throughout my time as a practicing physician, I've tried to ask and peel back the layers of what is it that really gets to the core of me doing my best to provide the care. And I think that was one of the genesis of how the three of us kind of bonded together to write the book that we're excited to share about today.
Excellent. And we're going to talk about that excerpt from that book, How Fee-for-Service Shapes Your Doctor's Decisions. So, Jonathan, for those who didn't get a chance to read your excerpt on Kevin MD, tell us what it's about.
First off, thanks so much for sharing the excerpt, and I want to encourage everybody to take a look. This is the excerpt that opens our book. And so one part of the inspiration for us to write the book was thinking about how, much like how, it's important to understand the physiology of the cardiovascular system or the pulmonary system to understand the presentation of a patient clinically, it's important to understand the physiology of our healthcare system. And so our book is broken into two parts. And the first part, what drives healthcare, is really trying to understand the physiology of our healthcare system. And of course, I'm a practicing primary care family medicine physician. And one of the most important assets we have that is, of course, most limited is time. Mm-hmm. And so often people are trying to understand, why is your time so limited? Why do I need to prioritize the number of things I discuss in a particular visit? And why can't I address every single thing for every single patient in every single visit? And really that drives at time. But why is time so limited? It's because of the way that we're reimbursed. And so our book, for every single physiology element of the healthcare system, which we call a systems factor, we introduce it with a continuous patient narrative throughout the course of the book. And the book opens, as does the excerpt, with this narrative coming for their first primary care visit with a new primary care clinician. And they have to prioritize what to focus on the particular visit. And we uncover that the systems factor driving that is the way that ambulatory care is reimbursed through fee-for-service. Once we land on that take-home point, we really dissect, how did the fee-for-service system come to be? And so we go through the original form of reimbursement in Medicare, which was usual, customary, and reasonable. We uncover sort of some of the challenges that arose from that early days of Medicare system. And then we take a deep dive into the research that informed how the fee-for-service system came to be. And then we outline exactly what fee-for-service is right now and how relative value units, the driver of fee-for-service, is calculated. That's a lot of dry material. And so we don't want to just be a textbook that provides dry material, but we want to make it real for people. And so we explain how this system, though very good intentions, might create the incentive to have as many visits as possible rather than cover as much as you can in a given visit. And so in this article, in this excerpt, we focus on the content as well as the implications.
And Jonathan, just to follow up, like yourself, I'm a primary care physician, but Through that patient example, just give us a sense of how those time pressures from that fee-for-service system, how does that infiltrate a typical patient visit? Just give us an example.
Oh, sure. So I think it infiltrates a particular patient visit the moment you open your electronic health record and you see that you have 30 patients to see that day. And, some of those patients might be quite simple and some of them are quite complex. But the amount of time you have for a simple patient and the amount of time you have for a complex patient might be, gosh darn, the same. And so you are incredibly limited in what you would be able to accomplish for any particular patient. For this patient, this is a complex patient whose journey we follow throughout the book, and she wants to talk about possible new developing dementia, knee pain that could be arthritis related, and uncontrolled diabetes, and you don't even have the patient's medical records. And you would love to cover all of those very, very important things, but on a visit where maybe the patient didn't arrive on time and your next patient, the clock is ticking and they're waiting and they're going to be upset if they don't see you. And then you're getting messages in your inbox and phone calls to the clinic that you need to address independent of your schedule. The fee-for-service system needs you to keep chugging along to see every single patient because that's how the doors stay open.
And Joseph, I'm an internal medicine primary care physician, and what Jonathan mentioned was completely reflective of what I do every day. Talk a little bit about how the fee for service came to be or evolved to be what it is today, knowing that it really focuses more on production, sometimes to the detriment of patients. How do we get to this point?
Yeah, great question. I think at the core of how fee-for-service came about, it was an incentive to try to make sure that people were adequately being reimbursed for the work that you were doing. Now, I think there's a difference over time in valuing the work that was being done. They're giving a distinction between the work that was being done and the outcome of the work that was being done. And I think we focused maybe perhaps a lot on the former, perhaps more than the latter. And then I think over time, gradually so, it became this chasm of let's do more, do more, do more, and do more. And clinicians, including ourselves here, we're always trained to work hard, extremely hard at what we do. And if we're trained to, let's say, provide a certain procedure or a certain diagnosis and a treatment plan, I think that's over time, it just becomes naturally ingrained as to do more, do more, do more. And I think it's the intrinsic motivation and the personalities of really, really, really hardworking physicians, the way we were trained, the way we were, quite frankly, rewarded for our work, that has unfortunately an unintended consequence of that, maybe put less emphasis on valuing the outcome more than the work that was being done in and of itself, that I think is one of the things we try to point to in this chapter.
And Joseph, have you heard stories where that focus on relative value units and productivity has that influenced physicians' decision-making process?
Great question. I think in my day-to-day, when I think about practicing in the ambulatory setting as well as the acute care setting, one of the things that I think about is what is the quickest way to get the job done, provide the care for patient. And sometimes that is taking a step back and kind of reopening the can of worms to say, this patient presents with a number of symptoms. Let's try to go through individually 1 through 5, what makes the most sense, ask a ton of questions, and try to do maybe not the most efficient or the treatment plan that I'm most comfortable with, but to try to uncover everything along the way versus, as kind of Jonathan alluded to, under the time pressure, knowing the things that I know and the things that I don't, and knowing that in the back of my mind, it kind of lurks, oh, this is the quickest way to treat this patient through the highest RVU that I'm familiar with, that the system incentivizes me to do. I think I often, speaking for myself here, sometimes jump to a higher RVU treatment plan or a treatment plan that I know that the hospital system or the healthcare organization that I'm a part of may value that I do and a part of the work, and that, quite frankly, that I'm measured on as part of the metrics that I'm with the system that I'm a part of. So I think that's in subtle, some ways, indirect and directly in some ways, that the RVU system influences the way I approach care.
And Joseph, just for those who aren't familiar with how physicians are compensated, talk to us about that influence of RVUs on compensation. Are physicians compensated in general for the more they do and the more patients they see?
Absolutely. For sure, depending on the healthcare system and in the healthcare organization, there's some variation throughout. But I will say, for the most part, I think a physician is reimbursed through multiple ways. There is kind of what we would consider a base salary of some sort, and then a portion, or sometimes a significant portion of that work is integrated to how many procedures or how many patients, as Jonathan alluded to, how many visits that he or she tends to provide. And so if you're a surgeon, I can assure you that someone doing 100 surgeries throughout the course of a period of time is going to get reimbursed or paid more than someone that does 10. So for example, when it comes to knees, I have colleagues that tell me all the time that I get paid more to do 10 knee procedures or knee replacements rather than perhaps providing, conservative treatment plans for chronic osteoarthritis in the knees over time. And so not only is there a RVU system that perhaps incentivizes surgeons to operate more than provide conservative care, but in addition to that, take it a step further, it incentivizes you to do more procedures rather than fewer procedures as well. So it is kind of a slippery slope that can occur over time.
So, Jonathan, we clearly articulated some of the detriments of the RVU system, not only on physicians, but on patient care. I know that there is a movement away from fee-for-service. We have value-based care, focus on metrics. Talk about some of the potential paths out of our fee-for-service morass.
Thank you so much for mentioning that. And that's actually also a very big focus of our book as well, where we take a deeper dive into understanding what even is value-based care, because that's a term that means a lot of things to different people. And it's important to at least have a primer so that we could have a shared vocabulary and understanding of what it means to do value-based care. Broadly speaking, value-based care is, I would say, a movement to transition away from a fee-for-service or volume-focused infrastructure and towards an infrastructure that rewards clinicians and health systems for achieving health outcomes at an affordable cost. And so the way that clinicians or health systems are paid can be different depending on the nature of the value-based payment model they're participating in. And so one way of paying in a value-based payment might just be getting a bonus for achieving a particular type of health outcome. You reduce people's blood pressure, you get a bonus. Another way of having a value-based payment model might be holding a health system accountable for the total cost of care, either for an episode of care, like a hospitalization or a procedure, or having them accountable for the total cost of care over an extended period of time, like a year or 2 years, et cetera. And if you reduce the total costs of care for that population in the episode or over the course of the year, you might get a bonus check where you share in some of those savings. Some consider that a shared savings payment. Another term for that is a reconciliation payment. Of course, in those models, if there's an incentive to reduce the total cost of care, one might say there's a potential unintended consequences of cutting on needed care or giving lower quality care. And often in these models, there's a gateway where you have to achieve certain quality outcomes to even be eligible for these bonus payments. And then lastly, there's completely shifting the pendulum away from fee-for-service. There's the notion of population-based payments. Another term for that is capitation, where you give an organization just a per member per month or a per patient per month or a per patient per year payment and say, here's the resources that you have to take care of this population. Have at it. You don't have to be based off of a visit-based infrastructure, but rather entirely based off of here are the resources you have for the year to take care of patients. Go for it. Some of the tweaks there can be, hey, let's say I get $20 to take care of a patient for a month. Taking care of a 19-year-old with no medical problems might be very different than taking care of a 62-year-old who has multiple medical problems and social drivers of health challenges such as housing insecurity. And so in some of these models, that payment is adjusted based off of their clinical and social complexity. This is an area that's pretty new. Our healthcare system's been experimenting with it over the last decade or so, but it's still a pretty nascent science, I would say. And there are a lot of different models out there, and this is really an exciting period to think of what's the best way to pay for healthcare, appreciating that there is no single best way, but maybe a combination of ways that meet the types of organizations and the types of geographies to better serve patients and communities.
And Jonathan, what do you think it's going to take to make a meaningful move away from fee-for-service towards one of those other models that you described?
Yeah, so I think it's going to take a lot for starters. One is I think there needs to be on the part of clinicians, a sense of sincerity on the part of insurers, that believing that insurers are actually trying to reshape the way we pay for healthcare to better support population health, rather than just holding clinicians and health systems accountable for another thing for the same amount of resources. I think we've iterated on different ways of paying for healthcare that often come with no more resources or maybe a penalty or with more responsibility. And so I think there needs to be a sense of partnership where clinicians feel that authentically payers and governmental organizations are trying to help them deliver better care at resource and give them the resources to do it. That's number one. Number two, the United States healthcare system is not one healthcare system. It's a million different healthcare systems with a million different payers, where, in a given clinical day, I see patients from a number of different insurers, each with different incentives. So there needs to be multi-payer alignment where everyone is singing the same or similar tune. And so if 90% of my patients, I'm incentivized to see more patients, more patients, more patients, more patients, but for 10% of the patients, I'm in the world's best, most population health aligned payment model, the incentives are just not there economically to care about that 10% to reshape the way we deliver healthcare. So there needs to be multi-payer alignment and a sense of true, authentic partnership between clinician health systems and payers.
And Joseph, just to jump on that, I was actually going to ask that same question. So, do you think in order to get that multi-payer alignment, it's going to take some federal policy movement in order for that to happen? Because independent of some type of federal regulation, do you see something like that happening where payers can get aligned on an agreed upon payment system?
I believe so. It surely won't be a panacea to have the federal government provide a one-size-cure-fits-all or one-size-cure-all solution. But I think one of the themes that we actually highlight in the book is that often so Medicare ends up being the trendsetter. Quite often that commercial payers and other payers follow the model and adjust over time. And so I think, as Jonathan alluded to, a lot of the nascent programs and the payment models that have come out over the last decade plus, I think since the Affordable Care Act, much of that, if not almost all of that, has been through Centers for Medicare and Medicaid. And with the growing number of, I think, Medicare beneficiaries, and perhaps more importantly, so Medicare Advantage beneficiaries, I believe in the coming decades, I recently read that it's projected to surpass, I think, more than the traditional Medicare beneficiaries over the next several years and over the decades to come. I think it puts another emphasis on having Medicare really trial, study rigorously, implement, and set a really good example so that, as Jonathan mentioned, all the multi-payers can look at their respective healthcare systems, the states that we all live in, and the settings that are differing by the states, and try to come up with an alignment that is specific to the region at hand. But I think a lot of that work, quite frankly, has to be done or set an example by the federal government, in my opinion.
We're talking to Jonathan Staloff and Joseph Joo. Jonathan is a family physician. Joseph is an internal medicine physician. They are co-authors of the book, Reshaping Health Systems, What Drives Healthcare and How You Could Change It. The Kevin MD article is How Fee-for-Service Shapes Your Doctor's Decisions. Now I'm going to ask each of you just to give us your take-home messages to the Kevin MD audience. Joseph, why don't we start with you?
Absolutely. I am so thankful for the work that I've been able to do with Jonathan and Josh on this book. This book was a labor of love for all of us. It came together as a genesis for us as we really peeled back layers and learned things along the way that one may consider, a hidden curriculum in the medical education. Why does something happen the way it does? Why are we so pressured to provide medical care in a certain way? And we really wanted to provide a book or design a book that was serviceable to trainees and medical professionals at all levels. And realizing that when we were coming through training not that long ago, a lot of these resources were scattered and not really consolidated at hand. So it was a passion of ours to try to not have one book obviously cover all the topics, but to try to do it as comprehensively as possible throughout the specific settings of care. And then secondly, we tried to bring this content in a way that was most practical and easily approachable for clinicians at all levels, which is, again, as a byproduct of our training, we are so inclined or in tune with vignette style learning and practice-based learning. And so we open every single chapter with a clinical vignette to try to set the stage for how this applies to every clinician at hand during their day-to-day. And we really hope, and we provide at the very end of the book, part 2, a lot of practical solutions or ways or interventions that clinicians, he or she, could use in their respective healthcare settings. So we're really excited to share this knowledge base, and it's been a labor of love, and we hope that many of you guys will enjoy it and be able to use it in their own ways.
And Jonathan, we'll end with you. Your take-home messages.
First off, thank you so much for having us. It's really a privilege to be here with you. So much of what Joseph said resonates with me. I would say that going through all of my medical education and training, for so many of my colleagues, we all appreciate that understanding the healthcare system is important. However, gaining that health system's knowledge for so many feels unapproachable, and the fine details sometimes can feel removed from the relevance to day-to-day practice. We try to address both of those things in this book. One, we want to make health systems knowledge approachable and achievable for clinicians and trainees at all levels. And second, for any health systems lesson we try to teach, we try to tie it directly to a clinical vignette. So people realize, oh, this thing that I've experienced so many times, this is the way it is because of this thing, or at least this thing contributes to why I experience what I do. Now, so much of what we discuss in part 1 of the book, What Drives Healthcare, discusses really macro level health systems factors. That could feel daunting to feel like, can I actually change those things? But in the second part of the book, How You Can Change Healthcare, really focuses on empowering clinicians to appreciate that they can make change in their own clinical environments at the micro level. But it's important to have tools to help guide you through making those changes. And so I also really want to encourage, for any clinician or trainee that feels helpless about being able to change their own universe, there are tools to help guide you through how to make change in your own clinical environment. So I hope this educates people and makes them feel inspired to engage more with health systems at the macro level, as well as where they go to work every day.
The book is called Reshaping Health Systems, What Drives Healthcare and How You Can Change It. Jonathan and Joseph, thank you so much for sharing your perspective and insight, and thanks again for coming on the show.
Thanks so much, Kevin.
Thanks so much.